Continuing our lecture on the spine, start specifically with the thoracic spine, the anatomy, the positioning, and the image analysis. So the anatomy of the thoracic spine includes the 12 thoracic vertebrae. They occupy the posterior portion of the bony thorax. These are unique in that they have costal facets on the posterior lateral sides of the vertebral bodies for the articulation of the head of each rib. The facets on the transverse processes are the articulation point for the tubercles of the ribs, with the exception of T12 and T11. So here we can see the anatomy from the superior view of the vertebral bodies. Here is the lateral view. Take note in the location of each part: the body, the pedicle, the transverse process, the lamina, and the spinous process. On the lateral view, you can see the superior and the inferior articular process and the inferior vertebral notch. These are important to note because these articulation points create the zygapophyseal joint as well as the intervertebral foramen. So the joints of the ribs articulate with each of the thoracic vertebrae, includes the facets on the body as well as the facets on the transverse processes. Here we have a diagram demonstrating the articulation point of each thoracic vertebrae with the inferior process and the superior process. So this inferior process of the superior vertebrae, so number 10 here, with the articulation to the superior articular process of T11, the articulation point creates the zygapophyseal joint. We also have the intervertebral foramen as well as the intervertebral disc spaces to note. Here we have the spine slightly rotated about 20 to 30 degrees in order to identify each of the zygapophyseal joints. As seen here on the radiograph, the space of each zygapophyseal joint. On a true lateral of the thoracic spine is when we will be able to identify the intervertebral foramina. Here we have the foramen, and here are the foramen demonstrated on the radiograph. So the procedures of the thoracic spine as well as for scoliosis. For the thoracic spine, we have the AP and the lateral as a routine. Oblique is also done to evaluate for the zygapophyseal joints. Now, special consideration for positioning. We should use a compensating filter for the AP projection or use the anode heel effect. For the lateral, we will use the orthostatic or breathing technique. Ensure that you have the proper alignment of the part. The spine is parallel to the image receptor, as well as using a lead blocker posterior to the patient for the lateral position in order to clean up any scatter radiation. For the APT spine, the patient can be supine or upright. Ensure that the shoulders are equal distance from the image receptor. Arms are resting at their side. As the part position, the mid-sagittal plane will be centered to the image receptor. If the patient is supine, to reduce the kyphosis of the back, we can flex the hips and knees to place the thighs vertical. If upright, weight should be equally distributed on both feet. Placing your image receptor approximately 1/2 to 2 inches above the shoulders to place T7 in the center and utilize the anode heel effect. Your central ray will be perpendicular to your image receptor, centering halfway between the jugular notch and the xiphoid process. Your collimated field will be 7 by 17. Your respiration phase will be suspended on expiration. Expiration reduces the volume of air within the lungs to create a uniformed brightness of the image or overall density. For the lateral spine, this will demonstrate the intervertebral foramen. The patient can be recumbent or upright. Left lateral helps to minimize heart magnification and overlapping of the heart with the spine. The long axis of the vertebral column will be positioned horizontal or parallel to the image receptor. If the patient is recumbent, flex the hips and knees for comfort. Ensure that the shoulders and the hips are perpendicular to the table to ensure that the entire body is in a true lateral position. Centering perpendicular to your image receptor and centering at the level about T7. If the spine is horizontal, your central ray will also be perpendicular. Column 8, 7 by 17. For your respiration phase, you'll use the orthostatic breathing technique or suspended respiration on a full expiration. For the breathing technique, it is used to blur the ribs and lung marking that overlap the vertebrae. If the patient can cooperate, you will specifically set your technique to be about 3 to 4 second exposure with a low milliamp setting. Here again demonstrates what the vertebrae look like in the lateral position, and it will demonstrate the intervertebral foramen. For the oblique spine, the patient can be recumbent or upright. Rotate the body about 20 to 30 degrees from a true lateral to create a 70-degree obliquity to the image receptor or table. Ensure that there is equal rotation of the shoulders and pelvis. Flex the hips, knees, and arms for stability. Align the spinal column to your central ray and alignment to your image receptor or table. Centering perpendicular to your image receptor at the level of T7, which is actually approximately 1 to 3 inches inferior to the jugular notch or 2 inches below the sternal angle. Your collimated field will be approximately 7 by 17, and your respiration phase will be suspended on full expiration. Again, demonstrating the zygapophyseal joints in the rotation of 20 to 30 degrees from a lateral. For the scoliosis imaging, the scoliosis generally occurs within the thoracic or lumbar. The vertebral column is divided into 5 sections: the cervical vertebrae, the thoracic, the lumbar, the sacrum, and the coccyx. The normal curvatures of the spine from a lateral perspective: the cervical has a lordotic or concave curvature. The thoracic has a kyphotic or convex curve. The lumbar has a concave or lordotic curvature, and the sacral has a kyphotic or convex curvature. The extreme curvatures of the spine includes the kyphosis, or maybe a hunchback or humpback look. It's the extreme curvature of the thoracic curve. Lordosis is the extreme lordotic curvature of the lumbar. For scoliosis, it's the abnormal curvature laterally from the mid-alignment, mid-sagittal plane of the spine. And the curvature can happen in the thoracic or lumbar. We have our normal, and then a slight curvature is also considered normal. It's the degree of rotation that distinguishes a true scoliosis spine. So for our typical scoliosis examination, we will perform a PA or an AP upright and a lateral upright. So consideration demonstrates for a radiograph, we're going to look at the degree of curvature with the force of gravity, so the patient must be standing. We will evaluate any surgical implants that are placed in the spine. Bending studies may be used to distinguish the curvature of the primary curvature as well as the curvature of the spine and its movement with surgical devices. A long image receptor will be used, as well as a 60-inch SID to demonstrate the entire spine in one exposure. Also note that you will have special radiation protection requirements using breast shields and gonadal shields that attach to the tube head. So for scoliosis, it is best to do the exposure as a PA in order to reduce the radiation exposure to the breast and the thyroid. In this image of our patient, a true scoliosis imaging will be completed to include the cervical spine through the hips, and your cassette will be about twice the size of your normal 17-inch image receptor. So this demonstrates how the patient will be positioned. However, your collimated field will be larger. So your patient is upright facing your bucky, ensuring that the mid-coronal plane is parallel to the bucky. Arms are at their side and you're centering perpendicular to the bucky. For the lateral, patient is turned whether a right or left lateral, preferably a left lateral to decrease the magnification of the heart. The mid-coronal plane is perpendicular to the bucky, arms are up out of the way, and you're centering to the midpoint of the bucky. For image analysis of the thoracic spine, for the APT spine, the spinous processes are aligned with the midline of the vertebral bodies. The distance of the vertebral column to the medial ends of the clavicles are equal. The distance from the pedicles to the spinous processes are equal. The intervertebral disc spaces are open. The vertebral bodies are demonstrated without distortion. To detect rotation, effectively detect by comparing the distance between the pedicles and the spinous processes of the spine. Compare the distance of the medial end of the clavicle to the spine. The side demonstrating the greatest distance is the side that the patient is positioned closer to. So we see a great deal of distance between the left clavicle and the vertebral column. This means that the patient was rotated towards the left. For a lateral thoracic, for accurate positioning, the vertebrae will be demonstrated in a lateral position. The intervertebral foramen are clearly open and demonstrated. The pedicles are in profile. The posterior surface of each vertebral body are superimposed. No more than a ½ inch of space is demonstrated between the posterior ribs. Intervertebral disc spaces are open. And the vertebral bodies are demonstrated without distortion. To detect rotation, evaluate the superimposition of the right and left posterior surface of the vertebral bodies and the amount of posterior rib superimposition. When rotated, the right and left posterior surface of the vertebral bodies are demonstrated one anterior to the other. Here on the zoomed in picture of the radiograph, there is one outline of the vertebral body as well as another. This indicates rotation. Scoliosis from rotation. On a patient with scoliosis, the lung field may appear rotated due to the lateral deviation of the vertebral column. The posterior ribs demonstrate differing degrees of separation depending on the severity of the scoliosis. So note the difference between a rotation or the patient's pathology. For the oblique thoracic spine, all 12 thoracic vertebrae must be demonstrated. For the zygapophyseal joints, for the anterior oblique projections or positions, the RAO position or the LAO position, it demonstrates the zygapophyseal joints that are on the down side. So an RAO would demonstrate the right zygapophyseal joint. For the posterior oblique position, for the RPO and LPO, it demonstrates the upside. So for an RPO, it would be demonstrating the left zygapophyseal joints. The zygapophyseal joints on the side of interest should be open. However, the amount of kyphosis will determine how many zygapophyseal joints will be clearly seen. For scoliosis radiography, we should see the evidence of collimation. The thoracic and lumbar vertebrae should be included, as well as the iliac crest, and the vertebral column. The column is centered to the image receptor. Here are the references for positioning, use of Bontrager as well as Murals, and your image analysis textbook.